Hello everybody, my name is Leonela Bastidas Granizo from the Catholic University of Guayaquil. I am a medicine student and you can see my social media right here, Twitter and Facebook. Today I'm going to talk about 2-year outcomes of surgical treatment of severe ischemic mitral regurgitation. Background. Ischemic mitral regurgitation is a serious consequence of coronary artery disease that carries a substantial risk of death from cardiovascular causes in proportion to its severity. Ischemic mitral regurgitation is anatomically characterized by remodeling or distortion of the left ventricle geometry that ultimately results in papillary muscle displacement, leaflet tethering, and impaired coaptation. For the subgroup of patients with severe ischemic mitral regurgitation, the prognosis is grave, with rates of death ranging from 15 to 40% at 1 year. Here's a little video about the mitral valve.
Hi, I'm Dr. Randy Martin, and I'm a cardiologist. So I thought it would be interesting if I could actually teach you a little bit about the heart. Now, it has 4 chambers, 2 atrial or receiving chambers, which sit on the top part of your heart, and 2 muscular or pumping chambers called ventricles, which sit on the bottom part of your heart. Your heart also has 4 valves, and these are delicate tissue-like structures which are designed to act as a system of one-way doors, ensuring that the blood flows in one direction through the various chambers of your heart. The oxygen-rich blood then returns through a series of veins into the left atrium. Now, sitting between the left atrium and the left ventricle is a delicate valve called the mitral valve. And when the mitral valve opens, the oxygen-rich blood in the left atrium fills the left ventricle, and then as the left ventricle contracts to send the blood to the body, the mitral valve shuts tight. Now, if a valve does not shut tight, it produces a condition called regurgitation. Mitral regurgitation is the most prevalent significant valvular condition today. So to understand it, let's actually go into your heart and take a close look at the mitral valve, or what we refer to as the mitral apparatus. If you stand in your left atrium, you're looking right at the mitral valve. You'll notice that it has a front or anterior leaflet and a back or posterior leaflet. Now, when they're closed, the 2 leaflets meet, creating a perfect smile. One of the most common abnormalities of the mitral valve that leads to mitral regurgitation is called degenerative mitral valve disease. This is a condition where one has abnormalities of the tissue of the leaflets themselves and the fine chordae. The chordae tendineae themselves may actually rupture, and then that portion of the mitral valve actually prolapses or falls back into the left atrium, leaving a large gap as the valve closes, which causes the development of mitral regurgitation. During mitral valve repair of a degenerative portion of the posterior mitral leaflet, the surgeon might actually excise or remove the weakened portion of the posterior leaflet, as well as the abnormal chordae, by doing a small triangular resection and then suturing the valve back together. The surgeon might also support the edges of that repaired valve with a specific ring implanted into the mitral annulus to give the valve additional support. This is called an annuloplasty ring. A well-repaired mitral valve prevents mitral regurgitation and again allows the mitral valve to function as it should normally.
Continue with the definition. In a randomized trial comparing mitral valve repair and mitral valve replacement in patients with severe ischemic mitral regurgitation, we found no significant difference in the left ventricle and systolic volume index, survival, or adverse events at 1 year after surgery. However, patients in the repair group had significantly more occurrences of moderate or severe mitral regurgitation. The next video is about the symptoms of mitral valve regurgitation.
So when patients have mitral valve regurgitation, they become short of breath. Early on, in the typical pattern, although not always, they become short of breath gradually over time, so that they begin to notice that they can do less and less before they develop the shortness of breath, and the shortness of breath becomes more and more severe with less exertion. The mitral valve is a very complex apparatus, and it's actually truly an apparatus of about 5 different structures: the annulus, the mitral valve leaflet tissues, the chordae tendineae, the papillary muscles, and the left ventricle. All of those things are taken into consideration when the mitral valve is leaking and not working right, because then we as physicians, both the cardiologist and the surgeon, have to figure out why that mitral valve in that particular patient is not working. And there are a whole host of different types of disease processes that result in the mitral valve not working well. It makes a difference in how we treat the patient and what we do at the time of operation. It's important to remember that when we discuss mitral valve regurgitation, there are degrees of mitral regurgitation. And basically, any patient will find 4 ways to refer to mitral regurgitation. It's either mild, moderate, moderately severe, or severe. The reason that's important is that most of the time we do not really evaluate a patient for surgical treatment unless they have severe mitral regurgitation. Now, there are certain circumstances and exceptions to that rule, but by and large, surgeons usually don't see patients until they have severe mitral regurgitation.
Okay, continue with the exposition. We have the methods. Randomly assigned 251 patients to mitral valve repair or replacement. Patients were followed by 2 years, and clinical and echocardiographic outcomes were assessed. Here I have a video which explains how surgeons repair the mitral valve regurgitation.
Unlike traditional mitral valve repair surgery, in which the sternum is cut and spread open, in a minimally invasive robotic mitral valve procedure, the surgeon manipulates a highly advanced robotic tool and makes only tiny incisions. The robotic arms are inserted through the side of the chest, which is even closer to the heart than if we open the sternum. We make keyhole incisions for the surgical arms, camera, and access tube. The tiny camera provides a view of the diseased valve. We see that the valve is oversized, misshapen, and doesn't close properly, which allows blood to leak backwards. We remove the misshapen portion of the valve and reconstruct it with sutures. We insert an artificial ring to reduce its size. We sew the ring into place, and the valve now closes properly, so blood no longer leaks back. After the procedure, only a few dime-sized scars remain, instead of the 6 to 8 inch scar in the middle of the chest associated with open heart surgery.
Okay, so this procedure was already explained in some videos before, and now we're just repeating it so that it can be clear. What were the results of this study? Among surviving patients, the mean 2-year left ventricle and systolic volume index was of 52.6 millimeters per square meters of body surface area with mitral valve repair and 60.6 millimeters per square meters with mitral valve replacement.
After the anesthesia takes effect, the surgical area.
This video is about the replacement of the mitral valve when you have a regurgitating valve.
Area will be scrubbed with a special disinfectant soap and may also be shaved. The surgeon will then make a 6 to 8 inch incision down the middle of the chest. The breastbone is then separated, the heart sac is carefully pulled back, and the heart is examined. At this point, a blood-thinning medicine called heparin will be given to make sure that the blood does not clot. The surgeon will then connect the heart to the heart-lung bypass machine with a plastic tube. Blood from the heart is then sent to the bypass machine through this tube. The machine supplies the blood with oxygen and then pumps it back to the rest of the body through the other tube. While connected, the blood simply bypasses the heart and lungs, but still reaches the rest of the body. After the heart-lung bypass is established, the heart will need to be cooled to keep it still. The atrium is gently opened to reveal the mitral valve. The surgeon will then carefully remove the old mitral valve. At this time, the doctor will select a mechanical or tissue replacement valve and will sew this into place with stitches. Once securely in place, the atrium will be closed with stitches. When the heart resumes its normal function and can support the body with its own pumping ability, it will be completely free of the machine.
Okay? Continue with the results of the study. 2-year mortality was 19% in the repair group and 23.2% in the replacement group. The rank-based assessment of LVES-BI at 2 years showed no significant between group difference. The rate of recurrence of moderate or severe mitral regurgitation over 2 years was higher in the repair group than in the replacement group. Here you have a little video about the comparison between the two procedures, or the replacement or the repair of the valve.
The goal of mitral valve surgery, and especially when we have a regurgitant lesion, meaning that the valve is leaking, we always try to repair the patient. And that's very important because the literature clearly shows that the long-term prognosis for the patient is much better if we're able to repair the valve. Now, we can't always repair the valve in every situation. There are patients who have valves that have both mitral stenosis and mitral regurgitation, or they have some type of mitral regurgitation that's not repairable. But in most cases, if it's pure mitral regurgitation, we are able to repair it, and we make every effort to repair the valve. In the circumstances where we cannot repair the mitral valve, we then have to replace the mitral valve. And there are two different options for replacement of the mitral valve. One is a mechanical option, the other is a tissue option.
Okay. There were no significant between group difference in rates of serious adverse events and overall readmissions, but patients in the repair group had more serious adverse events related to heart failure and cardiovascular readmissions. Conclusions. In patients undergoing mitral valve repair or replacement for severe ischemic mitral regurgitation, we observed no significant between group difference in left ventricle reverse remodeling or survival at 2 years. Mitral regurgitation recurred more frequently in the repair group, resulting in more heart failure-related adverse events and cardiovascular admissions. Thank you very much for watching. That's it.